All-on-4 surgery has essentially 10 steps. The first step is to numb the patient up. Even when the patient undergoes general anesthesia, we numb the patient up because, one, we want to be able to control the bleeding, and the anesthetic has epinephrine, which helps control the bleeding. Secondly, we want the patient to wake up very comfortable. Step 2 is where we start to make incisions around the teeth so that we can detach the gums. It's really critical that we detach the gums from the teeth and the bone so that we can see everything super clearly. Success depends on placing implants perfectly within the bone. And the tissue, the gums, it creates a very false security of where the bone is at. So we reflect the tissue so that we can see the bone clearly. If you reflect the tissue too fast or with a dull instrument, this can cause severe swelling and inflammation. And so it's really important to have the doctor take his time at this step. Step 4 is we start to extract teeth. This is where we're going to systematically extract certain teeth so that we leave room to place implants. We leave teeth in while we are placing implants to help us and guide us to know where this implant needs to be placed. Because if we take out all the teeth at once, we lose our bearings as to where the teeth, the future teeth, need to be. The implants need to be in the right position so that they are able to support the teeth. Again, extracting these teeth in the most atraumatic way and preserving the bone is something that takes time and practice. There's an infection there, and it's a little gelatinous piece on the end of the tooth. The molars in the back are traditionally the harder teeth to extract. They take a little bit more time. But underneath them often is where the sinus is. And so it is really critical that you take them out in such a way that we don't pull the floor of the sinus out with it. Step 5 is probably the most important and most commonly made mistakes inside of all-on-4. And that is making sure that we remove infected bone and we flatten the bone off so that it is going to be perfectly flat and cleansable, easy for the patient to maintain. As we start to remove the infected bone, you'll notice there's a hole on that side. That is actually where an infection underneath the tooth, it continued to grow and grow until it poked out that side. And this is when patients will report they have bubbles that come and go. I'm opening up that hole, making sure that we get all the infection and all the bacteria out of there. Again, this step here can be the longest step. This is where really you want the doctor to take as much time as he needs to make sure he removes all the infection and prepares the site and ultimately sets up the game to win. This is super important that the patient has a device that can be cleaned. And when the bone isn't flat, then it creates this rolling mountains, a rolling topography where bacteria can get in there and create problems long-term for the patient. You'll notice that there are 4 teeth, 2 in the front and 2 in the back, that we have not extracted. Those will be extracted after implants are placed, bone grafting, suturing, and scanning. Then we'll take those implants out. Those teeth out. Okay, so now we're going to just finish up with a little bit of smoothing of the bone. Again, to make it so that when we suture it up together, that we have a nice flat surface the patient can heal up on, and they can maintain the hygiene of the device. Now we're checking all the holes, making sure that we have floors, and to make sure that we know the topography of the bone. Now we're going to start to drill holes. These holes are preparatory for implants. Now the holes that we drill, we're not drilling them like other implants that we place when they are single implants in the mouth. we're actually angling these holes in a direction that goes towards the nose. It's avoiding the maxillary sinus. If we were to drill holes perfectly vertical, then the patient would have a hole directly into the sinus. You'll notice also as you drill these holes, they're right up against those teeth. Again, those teeth actually act as little guides to know where the implant should be. She has a very triangular ridge, and so we're going to put one implant right up in the front. Normally, there are 2 implants in the front, but in her case, we're going to put one right underneath the nose, right at the top of that triangle. The reason for that is we want to maximize the anterior-posterior spread. Think of it like this. It's like maximizing the 2 front tires and 2 back tires of a car, or the 2 front legs and the 2 back legs of a chair. So now we just place that first implant. We're going to place the second here, and there's a third. And as I'm placing these implants, I am certainly noticing it's very soft bone. You'll notice you can see that implant out on the side where that hole was. We're going to graft that in a minute. Now we're putting our 4th implant in. Okay, very tilted away from the sinus. We're putting PRF in, standing for platelet-rich fibrin, and that is to help put a barrier between the implant and the sinus, because I know I'm right up against it. So now we're going to put that implant in. It goes in. Now we're going to start to work on putting the multi-unit abutments in. Okay, these are angle correcting multi-unit abutments. Think of it as like a connection. We need a connection from the implant into the bridge. And because we're placing these implants tilted, this connection is going to go into the implant, and when it comes out, it's going to deviate and correct for that angulation. So what you're looking at is me putting the multi-unit abutments in and checking to make sure that they are pointing in the right direction. That when I have the patient bite down or me push the jaw into occlusion, that they are going down the long axis of the tooth and they're connecting with the lower teeth. These wands that you see coming out, or these little sticks that are coming out, those are basically the same axis holes that we'll be using for the bridge that connects in the future. So you're going to see an example of me correcting a position. So the anterior implant, when I was putting it in, I didn't like the position. It needs to be down further. So now I'm putting the implant in a little bit deeper. And I put the multi-unit abutment back in, try it again, and I'm going back and forth until I like the depth of where the implant is, and to make sure that when the patient's lower jaw comes into occlusion, that it is lining up with the teeth. I want to maximize the aesthetics, but I also want to maximize the function. What that means is when the patient bites down in these future teeth, I want them to be as close to what her original teeth were, but I want to be able to change the outside of it to make it look better. Again, now I'm putting some more PRF in here. Why? Because I'm putting a 6th and a 7th implant in. In the very rare case that we have implants fail, I want to have a couple of implants in the back that I could use if we had a catastrophic failure. I don't do this in all my cases. This is more instinct. And when I do this, the patients typically will give me permission before surgery to use my instinct, and the patient will pay very little compared to the overall cost. Because they're so soft, I do not drill a hole. You'll notice that all I did was just push the implant in. Because we're not connecting a multi-unit abutment to it because it's so soft, we're going to put a cover screw on. Okay, one of the last steps here is to bone graft. And this is super unique because most of all-on-4s are done by doctors that don't do bone grafting. It's considered a graftless approach. There's nothing wrong with not grafting, but I do believe in grafting, even though the clinical science says that most cases will do fine without grafting. I've had cases where I've had to go back in and I want to have bone there ready to go for future sites if something bad was to happen. Right now we're covering that hole that we saw earlier on, that infection hole. Now we're going to put PRF in a different place. This is more up underneath the soft tissue, under the nose and off to the side, because these are the sites often that I see patients have more inflammation, swelling, and pain. Now as we start to suture, we're suturing in a very special way. We're suturing in a way where we're not pulling the tissue so tight to cause even more swelling and inflammation. We suture, we tie the knot, and then we push the tissue down and flatten it out. This is super critical for short-term inflammation control, but also long-term, as far as being able to have a very flat architecture that's easy to clean. It all starts right here at the surgery. Okay, the last step is we put scanning markers on top of those multi-unit abutments, preparatory for intraoral scanning. Okay, so what this basically means is we're putting a little tissue former on top to kind of poke up out of the tissue that the patient will heal in until I see them tomorrow or 2 days from now. Most of the time, patients will receive their teeth within 24 hours unless we choose to do it in 48 hours for special reasons. You'll notice that those 4 teeth are still there. That is because those are the connectors to overall plan. If I take those teeth out, I lose my reference to the old. Basically, we have what she came in with, which was all of her teeth. That and my future design, these 4 teeth are used to connect those 2 different past and future.
All right, go ahead
and this is a moment that is super special.
Really white. I like it. Oh wow. Yep. I definitely have like less
Having
of a
a patient
face.
see themselves for the first time, for me, is the most sacred and the most special moment of my day. And the more people I'm able to do this for, it fills my heart and soul, and I'm so grateful for it. It truly is a blessing to do this every day of my life. I hope you've enjoyed this video. Hope you will see